Yes, this is a subgroup analysis of a larger study that was performed to evaluate the effectiveness of a new drug called Vyxeos. It's made by Jazz Pharmaceuticals, and it's really an interesting idea. It's a combination of the conventional drugs that are used to induce remission in adult AML. And so you have daunorubicin and ARC mixed together in a liposome, because it's been found the optimal ratio of those two drugs to each other when they're exposed to leukemia cells is 5:1. And if you give the drugs to the patients separately, or you mix them together, which you don't, you give them separately, they're metabolized at different rates, and so it's never 5:1 all the time. But this liposome keeps them at the optimal ratio until they're exposed to the cancer cells, and the idea was, is that any better? And the parent study, the large study, showed that there was indeed a significant effect, a higher rate of complete remission and complete remission with incomplete platelet or neutrophil recovery, and a higher rate at which patients could go to hematopoietic cell transplantation. The question that we wanted to ask in this study, which is taking the same group of patients and looking at a subset of the patients, was really to say, of those patients with the diagnosis of AML with myelodysplasia-related changes who achieved complete remission or complete remission with incomplete neutrophil plate recovery, how did they do? And there's really two questions. One is the subgroup of AML MRC, which is a morphologic and cytogenetic classification of AML. You have to have morphologic dysplasia or prior myelodysplastic syndrome or cytogenetics that are associated with myelodysplasia. And we'd previously reported of a subgroup of that AML MRC patients as to how they did in terms of the induction of remission, and the response in that subgroup of patients, which was the majority of the patients in the trial, but still a subgroup, was very similar to the overall. But for this abstract, we're now looking at the question of, are the remissions that are induced the same? That is, you could say that with this new drug, yes, you get more people go into remission. That's wonderful. Well, once they're in remission, then everybody's equal, and then it goes on. Or are the remissions achieved with Vyxeos deeper, if you will? And that appears to be the result. And so if you look at the conclusions that we found with this subgroup analysis, number one is that if you now look at just the patients who achieved remission, and it's about 48% of the people who got the Vyxeos, and it's like 31% or so of those who got the conventional 7+3. And now just start the clock at 100%. You got remission, now what happens? And you still see that the people who got the Vyxeos did significantly better in terms of overall survival. And then you could ask the question, well, how about of those who then underwent hematopoietic cell transplantation? And you benchmark it you landmark it from the beginning of the HCT treatment, and they still did better. So it just seems that even in this subgroup, the people who achieve remission with Vyxeos seem to have a better remission, if you will, a deeper remission, because they did better afterwards. So those are the kind of major conclusions of the study. There's a practical, I'll stand back from just the data and talk about what this means to the practicing hematologist and hematopathologist, and that's my background as a hematopathologist. It's kind of interesting because as you see your career evolves, you look back to when certain diagnostic categories were of interest, but maybe in terms of prognosis, but not in terms of what you actually did with the patient. And this is the AMLC with myelodysplasia-related changes is an example of that. I mean, we can make that diagnosis in the past, and it connoted a poor prognosis, but there wasn't anything you could do with the patient. You'd give them 7+3, or you'd treat them just whether or not they had the myelodysplasia-related changes diagnosis. But now all of a sudden it matters, because now for this this puts patients in this high-risk AML subgroup along with the therapy-related AML, so that these patients, once they get this diagnosis, you can do something different. You can give them this drug, this Vyxeos. So the practicality of it is now when you see a patient with AML, you really need to make sure, obviously some of these things are easier than others to get at. One is the prior therapy. Is there a history of prior therapy? Is there a history of previous myelodysplastic syndrome? Can this be documented? And sometimes it's a little difficult to get the records. The patient may have come from somewhere else. And so, but you have to think about it and say, yes, this is an important characteristic. This patient could be treated differently. And then the other major thing is the cytogenetics. And about a third of these patients or so fall into this category because they have these myelodysplasia-related cytogenetics, like the -5 and -7, this sort of thing. And there's a whole list of them. And so now the question is, it actually matters whether you have these cytogenetic changes. In the past, it was just a prognostic feature. And so the hematopathology lab and hematology service need to get together in advance with intention and say, okay, we're going to get some patients like this. We need to plan to see how we can get the cytogenetic results back fast enough so that we can use them to treat the patient with this therapy, because you want to treat them this way from the get-go. How fast you have to treat somebody with AML is going to depend on a lot of clinical characteristics and so forth, having to do with the patient. But you need to plan this ahead of time, because cytogenetics traditionally takes a little bit of time to perform, and there's significant costs associated with gearing up your lab to do this stuff stat, or to set up the appropriate fluorescence and situ hybridization strategies to get it done right away. And you wouldn't do that unless there was a good reason to do it. Now there's a good reason. So I guess that's, from a practical standpoint, it kind of said, hey, this is an important diagnosis. For the pathologist, you got to put it in a diagnostic line. It can't be buried in the descriptive minutiae. You got to say this is AML MRC, so that you can now give this patient the opportunity to be treated with this improved therapy.